Yes, very important question, and you are right. Traditionally, dietary strategies for Crohn's disease have mainly focused on the type of foods consumed. In fact, we at the Crohn's and Colitis Foundation initiated few years ago the Precision Nutrition Initiative to address the most common questions among patients with Crohn's disease, which is what should I eat? Now, while this remains critical focus of the foundation, emerging research now underscores that when people eat is just as important as what they eat. Multiple studies in the context of other diseases have shown that meal timing can independently influence circadian regulated immune and metabolic pathways, microbial balance, and adipose tissue biology, even without changes in calorie intake or nutrient composition. In Crohn's disease, the intersection of chronic immune dysregulation, disturbances in gut microbiota, and high prevalence of overweight and obesity establishes a strong case for examining time based dietary interventions such as intermittent fasting. Now, intermittent fasting is a dietary approach that cycles between periods of eating and fasting, shifting the emphasis from food choices to the time of meals. A widely used protocol is the 16-8 method, which involves fasting for 16 hours and eating for 8 hours window, such as from noon to 8 p.m., which was the approach taken in the current study. So, intermittent fasting has gained scientific and clinical interest due to its demonstrated benefits across several validated health outcomes. Previous research, including studies preceding Dr. Skotandaraman's work, has shown that intermittent fasting can lower insulin resistance and levels, suppress appetite, and reduce inflammation. It has also been linked to improvements in high blood pressure, cholesterol, and symptoms of Crohn's disease, as highlighted in this first time work by Dr. Kotandaraman, who is also a principal investigator of our precision nutrition initiative I mentioned earlier. Now, it's important to note, however, that while more research is still needed to fully elucidate the role of fasting in health and disease, there is a physiological rationale for the beneficial effects. These outcomes are not the results of something magical. Rather, they result from fasting induced changes in key physiological mechanisms. Two mechanisms in particular, metabolic remodeling and autophagy. So, regarding metabolic remodeling, intermittent fasting initiates a key metabolic shift, yeah, from relying on glucose as the primary energy source to utilizing fat stores, specifically known as ketone, as an energy source. This transition results in a reduction of fat deposits throughout the body, including visceral fat, as demonstrated by this study. In addition to the metabolic shift, fasting also promotes autophagy. This is an essential process whose name comes from the Greek self-eating. So during fasting, the shortage of nutrients, specifically amino acids and energy sources, triggers autophagy. This mechanism enables cells to recycle their own components, including damaged organs, toxic protein waste that accumulated inside the cells, and use them as alternative source of energy or nutrients. As a result, fasting not only provides vital nutrients during energy deficit, but also lead to a cellular renewal and improve cellular health. Interestingly, and I'm concluding this question soon, genetics research has identified mutation in at least 3 autophagy-related genes that are associated with Crohn's disease, suggesting that impaired autophagy might be the key pathological contributor of the disease. And this raises the intriguing possibility that activation of autophagy could be one of the mechanisms underlying the beneficial effects of intermittent fasting observed in this study. However, this is hypothesis and remains to be tested in the future. So to wrap up, in summary, the growing interest in time-restricted fasting in Crohn's disease is because it can be used as a strategy to trigger beneficial metabolic shifts and promote cellular renewal processes, offering potential advantages for overall metabolic health, reduced inflammation, restoration microbial dysbiosis, and disease management. Sure, and I think the most striking finding is the magnitude and speed of change um, without that, I mean, the speed of change of weight without dietary modification. Participants lost significant weight and visceral fat, approximately, I think, 5 pounds over 12 weeks, while the control group gained 3.7 pounds, despite that both groups were consuming identical daily calories and similar foods. In addition, and very important, the symptoms, there was also an improvement or significant improvement in symptoms with a 40% reduction in bowel movement frequency and 50% reduction in abdominal discomfort. And another very important finding was that participants in the time restricted eating group had greater microbial diversity, an increase in short chain fatty acid producing microbes, suggesting that gut microbiome and immune interactions might contribute to the restoration of intestinal inflammatory balance in these patients. Now, these results resonate for IBD care because they support the feasibility of a low cost, accessible, non pharmacological intervention that complements the existing therapies rather than replacing them to sustain remission. And maintaining remission is a key aspect of IBD care. Importantly, this is the first randomized clinical trial to demonstrate a benefit of intermittent fasting in patients with Crohn's disease, providing a rigorous evidence in the field that is hungry for validated lifestyle strategies. In my opinion, this approach meets a real clinical need of sustaining remission by offering a practical solution in synergy with pharmacological treatment strategies for Crohn's disease.